Hello and welcome to the Avrum Rosensweig Show.
Welcome to one of the internet's best podcasts, where we dive deep into the lives of the extraordinary and fascinating people who leave an indelible mark on our world. Join us as we explore their captivating stories, remarkable achievements, and unique perspectives that shape history and inspire generations. Get ready to embark on a journey through the lives of inspiring people unlike any other.
Hello and welcome to the show. My name is Avrum Rosensweig, and I am just delighted to be here with you. Thank you so much for joining. You who have listened to the show in the past or watched it know that the show really is all about patting humankind on our backs. And the idea behind that is to recognize the brilliance of what we have achieved throughout our history. There's an awful lot of talk out there that is of a negative nature nowadays. There seems to be a bit of a cloud hanging over us in terms of who we are. And I want to get away from that. I would like very much to actually go to the other side of the mountain, if you will. And that is to recognize that despite our foibles, despite our pockmarks, we have done some absolutely incredible things everywhere in the world. Doesn't matter where you go, whichever continent you want to travel to, whichever country, whichever city. There's absolute magnificence right outside our window. And the way that I bring this magnificence to you is through what I consider to be inspirational interviews. I'm very fortunate to have a very large community, and I know a lot of people who have done some really magnificent things. And I simply ask you, when I do my interviews, as I am today with a dear friend of mine, that you listen to his trajectory in life, the challenges that he has or had in arriving where he's at today, which is a wonderful place, and think to yourself, excuse me, how can I hit my stride? How can I get into the zone? How can I find my passion? And if I'm there already, how can I develop it and make it stronger? We have a lot to be thankful for, a lot. And I think it's incredibly important that we see those things, that we're cognizant of them, and that we build upon them towards peace, greater peace in our world. So let me begin by introducing to you one of my best friends, Dr. Michael Silverman. How are you, Michael?
Very good. Thanks for having me.
It's great to have you. It's great to have you. Michael and I have known each other for many, many years. And not only are we friends and have been, we have also done a number of professional things together. We will touch on them throughout the show, but suffice it to say that in 1997, when I launched Via Hafta, the Canadian Jewish Humanitarian and Relief Committee, a Jewish humanitarian organization, I did so holding hands with Dr. Michael Silverman, metaphorically, I believe, right?
Occasionally in person, but yeah. Usually.
Sometimes we would hold hands, yeah. And together, we created this wonderful organization that really was reflective of the kindness and the goodness and the adage within the Torah of V'ahavta l're'echa kamocha, that one should love their brother and their sister as they love themselves. And we set about taking the Jewish community of Toronto, of Ontario, of Canada into the world. Places like Zimbabwe, the rainforests of Guyana, Haiti, Israel, Tegucigalpa, Honduras, and many, many other places. And our goal was to give of ourselves as Jews, as good human beings, to those individuals who by chance, lack of luck, if you will, were born into an environment where their medical care was $1 a year, $5 a year, whereas we who live in Canada in the West, our medical care probably on average is, what would it be, Michael? How much do we spend on each citizen?
Generally, over between $12,000 and $15,000 would be the overall, with some people, of course, requiring way more and some requiring less.
So since then, your career has developed dramatically. You now live in London, Ontario, Canada, and you are an infectious disease doc, but really you're responsible for all ID in the area, correct?
Yeah, I'm the division chair chief for Western University. So for the people living in this area, but I've got a great team that I work with, but I am the chair chief.
Do you adore being a doctor?
I'm really lucky, you know. A lot of people, say, well, if I had been this and if I had been that, and I must admit, every once in a while, I play out in my mind, well, maybe what if I had done this? And I always come to the conclusion, boy, I lucked out. I mean, I found something that I really love, and the truth is, it's hard for me to even say I found it. My dad told me, do this,
Yeah.
become a doctor. Like not uncommon for Jewish parents, and he told me that, and I said, "Well, why?" He said, "Yeah, it's great. You'll find it's wonderful. You can help people. You got, he said, you're like me. You got a lot of empathy for the poor and they got OHIP, so you'll get paid for it, and you can help the people who are most in need, and it'll be great." And he was right. Like it's been a delight. It's been something that's given me great pleasure in my life and great opportunity, challenge, and it worked out way better than what I hoped for. So I feel really lucky and blessed.
I often wonder about how people feel inside versus their externals. It took me many years to be able to call myself an artist. Many years.
Mhm.
And part of it was, had I sold anything? In other words, the idea being that you're only a professional artist if somebody's bought a piece of yours. Okay, maybe not. Inside, in your heart, if I were to say to you, who are you? Name three things which define you best. What would those three things be?
Yeah, it's hard to it's hard to narrow it down. Am I a doctor? I think that is part of my persona and part of who I really am. It took a while to feel that way. I mean, like you talk about being an artist. When I went to med school, there was a guy in first year. He was a caretaker, and he would go around and greet all of us as we're walking around the halls as, "Oh, hello doctor," and we'd been in med school for like 2 months at this point, and it was shocking, and it was shocking. And I thought, oh well, this feeling will go away. It didn't go away for a long time. When I graduated med school, to be called a doctor still was, well, I mean, technically, but not really. Like I don't really know what I'm doing. So, and you're a resident, and then you're a fellow, and then a postdoctoral fellow, and doing all this stuff, and still it didn't quite feel real. And then you go into practice, and it's like, yeah, I know I'm functioning like a doctor and I'm doing everything, but I'm really new. And if people really knew how new I was, back then I had to grow a beard so that I would look older, so that I would look old enough to really be a doctor. Unfortunately, I no longer need the beard for that reason. I definitely look old enough to be a doctor, but now I just keep it out of habit's sake, and because because when you're playing with the kids, they still like it when you feel fuzzy.
Yes.
But it took a long time to feel that it's real. And I must admit, even after being in practice, for over 30 years, I still sometimes go, am I really a doctor? But that's just because it has so many things in our culture that it means, and that but it's been a delight trying to live up to what I feel a doctor means. It's been a delight to try to aspire to be the best of what I think a doctor needs to be.
Well, what are those things in our culture?
Well, people think doctors know everything, and doctors do not know everything, and they do. No one can know. They know at least everything about health. Well, nobody can know everything about health. Well, they know everything about their discipline, and nobody can know everything even about their discipline. I'm an infectious disease doctor, and I do not know everything about every infectious disease. But I did learn there was a guy who was a hero of mine, and Roy Roussel was a physician, and who was of the old school, who walked around everywhere with a black bag with all his instruments, and when he sat down and he talked to a patient, he'd take 2 to 2.5 hours to get the full history and where did you serve in the war, and like all this stuff to get to really know the person. An old-fashioned internist who really wanted to know everything about you so that he could really do what's best for you and really understand where you came from. And as he got older, like I aspired to be like him, because of who he was in many ways. But I also noted that when he got older, like beyond a certain age, I mean, he was still practicing at 85, and medicine had moved a lot, and he'd gotten kind of frail, but he still was an awesome doctor. He still was an awesome in every way, what really was a great doctor. And if he didn't know about something, if he didn't know, he thought, oh, there's something new about that. I didn't. He'd consult and he'd call. And he'd ask, and he'd make sure his patients got the very best care. And the fact that he didn't know everything didn't matter so much because he was humble. And his goal was to get the best quality care for his patients. And he made sure they got that. And then I learned that what's important is, you try the best you can to learn as much as you can. You try as best you can to remember and learn, and even more important, to know where to find the information. But if you have the good intention of trying to really do what's best for the person, you can deliver awesome care by working within a community of physicians and nurses and social workers, etc. And being a doctor is providing real care, and that's what I see as what I can aspire to, whereas knowing everything is not something that anyone can really aspire to.
Now you have two little boys here in London. I shouldn't say here, but in London, Ontario.
Yeah.
And you have an older son who lives in the United States, right?
Yeah. So I've got a 34-year-old.
Yes.
Who's an academic at Penn State, and Justin, and he does computational biology and statistics. He's
right, whatever that is.
Yeah, and he's a math genius, and he married another math genius, Rachel, and they I'm sure nothing they did in life is as important as they gave me 2 gorgeous grandchildren, Isaac and Ari, that are a delight. And then I've got a lovely wife and 2 kids here, twins in London, so who are both 9 3/4. They're still at the age where they count the quarters, and Adam and Max, and I'd like to say they keep me young.
Yes.
They force you to behave young, even if you're not feeling that way.
Very much.
And sometimes if you behave that way often enough, then you feel that way. Although sometimes they look at me going, they do the math and go, how can you be a Zeta, a grandfather, and a dad at the same time? And I say, well, in our world, these things are now possible. They used to happen all the time in the old days when women would start having kids at 17 and 18 and continue till they're 42. But nowadays it still happens, and it's a blessing, especially when my 9-year-olds are playing with my grandchildren together. It's lovely to see.
Now, you're in my mind and many people's minds, a very important, a very auspicious doc. And your resume is so long that if I were to read it, we'd have to do a part 2 of this podcast. So there's a lot of people out there who respect you. There's a lot of people out there who come to you for advice. I'm certain when you walk into the hospital in the morning, you put on your white gown and you put on your stethoscope, that the questions just flood in. Doctor, we need your help with this. We need your help with that. The fact that you're a doctor, when you go home at night and you go through your front door, does it mean anything or much to your beautiful wife and your 2 little boys that you're a doctor?
Not much.
Not much, right? Right? Yeah.
Not much. Most of the time, it's not really relevant, and that's good, because we all need a life outside of our profession. So every once in a while, my kids will be kind of surprised when I talk about stuff that I do at work, and they'll say, "Oh, you really do that? I thought only doctors on TV did that." No, I do that, but like not you. I'm not you, Dad. No, I do. And but for the majority of the time, when you're talking about going to play pickleball, or going for a bike ride, it's not really relevant, and that's healthy. We all need a break from our professional persona.
So you don't carry it home with you at all?
Sometimes it's interesting and things happen that are, like that are academic or whatever that you share. But I'll say, as much as I share stuff that I think is really interesting about, how the body works or whatever, I'll be sharing just as much stuff about, like I love to read about what happened new that we found about Mars. And the kids are fascinated. They treat what I do at work and what we talk about with astronauts with equal interest and equal, but it's not really relevant to us because, dad's dad. That's not really there.
Have you ever taken them to the hospital?
Well, I have a little bit, but and sometimes they're kind of shocked. Usually I take them to the hospital because somebody needs stitches and fell or something.
Yeah.
And then they're kind of surprised when people around know me.
Yes.
And that, I walk around and show them where I work a little bit, and it's kind of, their eyes open a little bit. But very soon after you get home, they forget all about that, and you're just dead.
Did Susie fall in love with you in part because of the things that you do in the world having to do with medicine, because of the medical work that you did in places like Zimbabwe and places like Guyana? Was that part of the allure for her?
Yeah, like most guys, I spend a lot of time wondering why she fell in love with me.
Yeah.
And thinking that, boy, she could have done better. But I think it was part of the package, I guess. But I do think that more it's who you are, rather than, we think that if we accomplish certain things that will make us lovable, but really it's not about that. Being lovable is about being nice to people and listening to them, and caring about other people. I think that's what's far more important. And especially for the long term, having a nice CV might get you a second date.
Yeah, nicely said.
But it's not going to make someone say, I want to spend my life with you. Because if you're not a nice person, but you're a Nobel laureate, it's still not really a great idea to spend your life with them.
I want to tell my listeners a fascinating story. I have some problems with my heart, and I have had 3 heart attacks. My very first heart attack, which I remember fondly, I was taken to the hospital. And the first thing that I did was to call my very, very dear friend, Dr. Michael Silverman. And I did that for two reasons. One is he makes me feel safe. And two is his doc. So one always likes to have someone advocating on your behalf when you're in the hospital. In fact, doctors and nurses say, have somebody who's doing that. Have someone who's pushing your case. So I phoned Michael, and of course he said, of course I'm going to come over. I just want you to know I'm on my first date with it happened to be Susie, whom he married. And probably within the hour, I remember him walking through emergency and coming to the cubicle where I was lying. And there he was with Susie again, your first date, ultimately the woman that you would marry. I think, tell me if I'm right, Michael, when you told her that you had to go to the hospital, did she say, you're kidding me? Like, there's no way, or what?
Yeah, well, I mean, the thing was, you called, and it was on a first date, and I didn't know it was urgent, so I must admit, I put, I'll pick it up next, and then you called again.
Yeah.
I said, okay, I better pick it up, and then Susie's version is I just, I put the phone to my ear, and then I said, oh no.
Yeah.
And I won't use the expletive that I use repeatedly. And I said, we got to go. We got to interrupt dinner, and we've got to go. We've got to go to the hospital. And she's like, really? Yeah. And got to go over to the hospital. And we went straight over. I must admit, we did stop in the parking lot for our first kiss, and then I went upstairs to visit you.
I didn't even know this.
Yeah.
I never knew this.
Yeah.
Okay.
So
you delayed for a moment.
I delayed for a minute.
Okay. All right.
It wasn't prolonged, but I felt really appreciative that she came with me to go to the hospital on a date, and we skipped. I said we'll forget dessert, maybe we'll do dessert later. And then we went upstairs, and you commented on how we were holding hands when we went upstairs, and but that was the first way she met you, and our first experience together is sitting down and seeing you on a stretcher in the emergency department at the local hospital.
Michael, as a doctor, are you a bit like the neighbor with a pickup truck? Like everybody wants to call you and use you for something?
I get that a lot.
Yeah.
I get that a lot.
Yeah.
Now I'm not I'm not a family doc. I'm an infectious disease specialist, and most people know that. I mean, you do internal medicine first, so you have some general knowledge. But I am an infectious disease doc. But if anybody's got a fever or a rash or spots something, or they're traveling somewhere, I do tend to get a call, and it's sometimes you feel like, well, I do this at work all the time, but then I put myself in their position, like, people are scared, and they don't know what to do, and so it's a privilege. I feel it's a privilege that I can help people when they need it. So, I mean, sometimes your first thing is like, it's 3 a.m, and why are you calling me? Because there's a system. And then after a few seconds, you start going, wait a minute. They're doing this because they're scared.
Yes.
And sometimes they have something to be scared about. And I feel lucky that in many cases, I can answer the questions. So you can alleviate their concerns, and sometimes you can bring some help. And that quickly overwhelms everything, and you realize, I just feel lucky that I'm in the position that I can do these things.
Have you ever been that doc on the airplane? Is there a doctor on the airplane? Have you ever been that guy?
Oh, yeah, many times.
Oh, you have?
Many times.
And do you respond immediately?
Yeah. You get up and you go, and sometimes, you're able to do something really, really helpful. I've had a couple of dramatic things that have happened on transatlantic flights, where you're in the middle of nowhere and you really have to act. Sometimes they call and it's because somebody opened the overhead bin and something fell on someone's shoulder and it hurts. But sometimes, I've had to deal with, anaphylaxis where someone was dying of an allergy and they said that shouldn't be, I'm not allergic, that I didn't have anything, but it ended up that they had the peanuts and they're not allergic to peanuts, but the peanuts had some coconut oil on them and they are allergic to coconuts, and had to do the whole thing. I had to actually make a hole in the neck and, with a blade and open up the neck so the person could breathe. And, so it really did save their life, which was really nice. And
When
I
you're
had a couple other times where the plane was going to have to turn around and was able to, and make it. One was where the patient was going to have to make an emergency landing at Gander, and we were able to resuscitate the person. So now, partially, you say, well, why have there been so many stories? Well, I did a lot of traveling.
Yeah, you did.
I did a lot of traveling for my work doing in developing countries. So I was on planes a lot. So yeah, over the course of that time, things can occasionally happen.
When I was running Via Hafta and we would have our gala and I would be on stage with Mia Farrow or Elie Wiesel or some very auspicious personalities, I remember the feeling being there. For those moments, I felt very, very central to what was going on in the world and very special. But even more so, when the gala was over, I would always make an effort to go to Tim Hortons coffee. And I would sit there, and of course, I'd be surrounded by these old Greek guys, solving the problems of the world. You would hear them, their discussions. And I would be thinking to myself in those moments, and not in an arrogant way, but, oh, they have no idea where I came from. They have no idea what I just done. They have no idea who I was on stage with. When you walk away from sticking that blade in someone's throat to allow them to breathe, and the plane lands, and you start walking on the tarmac in some developing nation, do you think to yourself, my God, look what I just did? If these people only knew. Do you feel that way at all?
We're all complicated people. And I don't think that way so much, because I think that's part of who I am, but it's not all of who I am. And so I don't think I don't think, I think I've been given a great gift that I've been trained to do these things that are really cool. But I don't think that makes me particularly special, that everybody should defer. So I do think it makes me lucky.
Yes.
I do think that I'm very privileged, but I don't think that people should defer to me because I'm just a guy.
Let me reposition this a little bit, because I'm sort of stuck out on a ledge now. I'm just kidding. Kidding. What you have it within your hands to save a person's life. You also have it within your hands to lose people, right?
Sometimes.
I'm just curious, what does that do to you as a human being, existentially?
In infectious disease, we see a lot of people that have mysteries, and you try to, they'll have a fever or they're getting sick, and the big problem is to figure out what's the matter, figure it out quickly, even when you don't know how to temporize or how to stabilize in a way so that you give the right antibiotic, you do the right test, or you find out where the problem is coming from, and you got to figure it out. And even if you don't know exactly what it is, and the top 4 or top 13 things that it could be, make sure that what you do will be best for those. And so there's a lot of living with uncertainty. And you have to do your very best to make sure you don't miss something, and you also have to make sure that you're not so over the top at covering for every possibility that you harm someone by doing more than you should be doing. So it's a difficult balance. It's a difficult way to walk, and it's not special about it. All physicians have to walk those lines to some extent. And I remember the first day of med school, there was a surgeon who got up there, and he was a retired surgeon, but he got up there and he said, "All of you will do your best, but at some point in your life, all of you will make a mistake because you're human."
Yes.
And one day you'll have to look yourself in the mirror and say, something terrible happened, someone died or was maimed or something because I made a mistake. And I wish I hadn't made that mistake. It's not out of malice, it's just I'm human and didn't think of it and I didn't notice. And you have to live with that. And if you think you can live with that, knowing you did your best, and then that's great. Then stay here. If you think you won't be able to live with it, if you think it'll destroy you, then leave. Mm-hmm. And that was on the first day. It was pretty intimidating. I must admit, I've been incredibly fortunate because it hasn't happened, or because I don't have the insight to know when it happened. Mm-hmm. I've never had to face that. So have I ever faced that? Yeah, maybe I could have made a different decision or I could have done something different, but never where it led to irretrievable damage. So I feel blessed that way too, that it hasn't happened to me, because I have seen it happen to others, and it is devastating. It is devastating because people, they've devoted their lives to helping people, and then when you realize that, wait, you're just human, and as humans we fall short, it can be very hard to live with. But fortunately, that hasn't happened to me yet. But I do fully recognize that it could happen.
In 1998, Via Hafta went to Zimbabwe, a small area called Glendale, where there is a hospital called the Howard Hospital. Excuse me, I have a bad cold. We liaised with a Dr. Howard, the Howard Hospital.
Paul Thistle.
Dr. Paul Thistle, I'm sorry. And I interviewed him a few weeks ago. You can catch that interview on YouTube. And I remember that you called me because it was at the same time when HIV/AIDS was prevalent, was rampant. And I don't remember specifically, in the way I've told the story in the past, was I believe you were almost in tears because as an infectious disease doctor, you are trained to look for solutions. You have the resources in Oshawa, where you started out, and now in London, where you've worked, and other places around the world. You've worked in Detroit and Michigan. And you said to me, Avrum, I don't know what to do. Like, I don't have the resources to do what I would even like to do. And that has always stayed with me. It's always stayed with me because I've often wondered about who Dr. Michael Silverman are you, that you were so upset, you were so sad looking around and seeing the suffering and feeling almost useless. Am I accurate in my memories?
Yeah, so to give some context, so I graduated med school in 1985, which the AIDS epidemic was just taking off, and then I did training and I went into practice, and I was I was doing training in the late 80s in infectious disease, and then even in the early 90s, and we saw enormous numbers of people who we lost, all kinds of wonderful people, And the HIV, which was made up a large proportion of my practice, basically we were helping people through the grieving and death process. And we were trying to slow the progression. But there was no question what the ultimate outcome was going to be. And it was devastating. And to have to see that in so many people. And then in 1996 was the miracle of the antiretroviral drugs actually started working, because we actually started getting combinations of 3 different drugs that we could put people on. And people went from being really terribly ill. I remember so many examples of people curled up in a bed, wasted away, and likely not having much time left on this earth. And then starting them on the medication and seeing people start to regain their weight, get up, and like it was like coming back from the brink. And I remember some of them, one guy in particular, who then I had seen him curled up in a bed, barely able to talk, to giving a lecture about his experiences and standing at a podium, having recovered. It was amazing. It was amazing. And I remember a friend of mine, Gord Arbus, the first time that this happened, he's a doctor at St. Michael's Hospital, and we were both working at the old Wellesley at the time. And like the first time I saw one of these patients who I'd given this medication to, and he got better, I was like shaking. And I came out and saw Gord, and we just hugged each other. It was like, oh my God, there's hope. And it was amazing. And then to have gone through that, and then to go to Zimbabwe, where the numbers were astronomical, and we had no access to those drugs again. Like, the drugs were not available in Africa for quite some time after they'd become available in North America and Western Europe. And their numbers were enormous. And I knew if I could just get access to them, I could help these people. And yet, we just couldn't get it. The costs were astronomical, and no one was gonna pay for that. And so there was a great deal of despair initially until I thought about it a lot, and it was very troubling. And then we had to decide, okay, well, what can we do? I have to focus not on what I can't do. I have to focus on what we can do. And there was huge numbers of young people, and particularly young women. There was a lot of young men as well. And one of the first patients I saw in Africa was a baby who was dying from AIDS on the pediatric wing, and the father had already passed away, and the mother was sick on the maternity ward, and the baby died shortly, within a couple hours of my meeting, him, and it was in terrible pain. He was crying nonstop until there's this condition called rapid sepsis that develops rapidly that can happen to some of these babies. And I thought, well, at least preventing the baby getting the HIV, that's something that wouldn't cost that much. Because if we could just get the mom the meds for a short period of time while she's, towards the end of pregnancy and the time of delivery, because we knew that was when most of the virus was spread, was right at the end, most commonly at the time of birth. This is early on. We now know that we can do more than just that, but at least that's something we could do for a very small amount of money. And so we pulled together a team to do this and to develop a regimen that we could give for, of HIV meds just for $4, just to give the mother 3 capsules. I remember during labor, and take 1 capsule and dissolve it in water and use it, through an eyedropper, and give it to the baby by mouth for 3 days after birth. And And we were able to cut the transmission rate by over 50%. So we could save a lot of babies for $4 a treatment. And so the focus, now I must admit, it was still every once in a while you'd look around and say, look, all the stuff we're not doing.
Yes.
And initially, all those mothers, unfortunately, were doomed. But at least we could save the babies for a bit. And then eventually, the cost of the meds came down, resources came up, and we were able to focus on saving the mothers as well. And it grew, and we were able to prevent breastfeeding transmission, and we were able to do more and more. But I did learn that the way to deal with that despair was to focus on what we could do and to put all my efforts into what we can do, which as an organization we have to did and really pulled through and did. There's all kinds of stories about how we made that happen. But many wonderful, wonderful people, and particularly Paul Thistle, who is a full stop hero.
Yes.
He is just literally a hero. He doesn't wear a cape, but other than that, he fills every criterion for a hero. We were able to make a difference, to make a real difference, and I do, and I kept, as a Jewish guy, I had the felt very strongly about the analogies to the Holocaust, where there so many died, and like Oskar Schindler, that well, you save some, but look at how many you didn't save, and he's crying at the end. But to focus on those we could save, and we were able to save quite a few, and many of those babies grew up, and many of those babies really started families of their own and did great things. So and there were some people who said, you shouldn't be doing this, you're creating orphans.
Yes.
And we had some real pushback on some people saying this is unethical, you should not be doing that. And my argument was, well, according to that, all the babies during the Holocaust should have been just thrown into the ovens because they're not going to make it. But some of those babies grew up to be Nobel laureates. They may have been orphans, but that doesn't mean their life is over. I mean, it's much better to you got a much better shot if you're not an orphan, but it doesn't mean your life has no chance. And so it's going to be hard, but life is always better than not having any options. So I think we did some wonderful things, and Viahafta was critical in making that happen. And as time got on, we did bigger and bigger things in terms of being able to hopefully save the whole family, which now wonderfully can be done.
Michael, there's a certain magic that I've always seen within you. And when you mentioned to me a little while ago that you're reading the Harry Potter series to your boys, your little guys, I wasn't surprised. You said it's a phenomenal, phenomenal story. I think you're on book 5. It's about 800 pages. Is that correct?
That's right. We just finished book 5 last night. So we sell. The rule is we have to read the book and then we can watch the movie.
So how much would you read a night to your boys?
Well, it depends how late it is and how quickly they fall asleep.
Yeah.
So if they, particularly Adam loves to read Harry Potter, one of the twins. So he loves that. Max thinks it's kind of gory and he'd rather read about rocks and minerals, or right now we're reading about Egypt and the pharaohs. It depends, but basically I read until they nod off, and try to get them to read the first few lines at least, so that hopefully they practice their reading. But very quickly they would rather relax and listen to my voice rather than do their own reading, and that's okay.
It's a very beautiful moment when they nod off, isn't it?
It is.
It's beautiful.
It is. And then you got to get up very gently from the bed so you don't wake them up.
That's right.
Get up, because then if you wake them up, if they
You're in
stir,
trouble.
trying to get, Well, oh, no, I wasn't sleeping. I wasn't sleeping. Just a little more.
The reason I mentioned the magic is because when I look back on those days, you were the director of our science and medicine. I was the executive director of the organization, and we worked hand in hand. And it was a young organization, and therefore everything shone. Everything shone. Everything was beautiful, and we were willing to take many risks, and to accomplish many things because of it. One of the instances that comes to mind is that we would send docs or medical personnel over to Zimbabwe, to the Howard Hospital, as we did in Guyana, and we'll touch on that in a moment. Now, we sent a doctor there, Dr. Rachel, who she delivered twins, but they were attached.
They're conjoined.
They were conjoined twins. Now, here you are in rural Africa, and the resources just aren't there to save their lives often or to separate them. So we set about getting in touch with Sick Kids Hospital here in the Herbie Fund, and ultimately bringing those twins to Toronto together with their mom, and surgery was done on them, and they were separated. When I look back on those days, Michael, I see the magic, and I thank God. I thank God that we were in the place that we were at the time that we were, and that we were ultimately able to actualize our gift of having resources in the world, our gift of knowing what to do and giving it a shot, and giving those little kids a chance. Now, I know that years later, you actually saw those little ones running around,
Yes.
and like you said, having a life.
Having a life. There's no end of these opportunities.
Yes.
It's not like now things around the world, everybody gets what they need. So, and we'll never, I mean, there's repairing the world, which is what we always are obliged to do. But then there's finishing the job, which of course we're not obliged to do because it's impossible. So there are a ton there are unfortunately millions of opportunities to help people in need, because there's so many people in need who still need help. I mean, once I had my boys, I started focusing, traveling extensively was not such an option. And so I started focusing on helping people who inject drugs and who are needy in North America. And there's lots of need here. And then there's lots of need. There's no shortage of terrible of people living in desperate situations that often can be helped with small interventions. And I mean, the conjoined twins was wonderful and was a marvelous experience for all of us. It was a bit of a Herculean effort, and they deserved it, and we wish we could give. But there's also so many opportunities that require small interventions, and we have to do both. We can't say, no, wait a minute, this is too much, these people are not worth it, or are not worth it. But we also have to take opportunities where small things like, vaccinating a community, that for small amounts of money can make a massive difference. I remember in Guyana, there was huge problems with worms in, this is the people living in the Amazon rainforest, a lot of indigenous people. But even outside the indigenous, there were many South Asians and Afro-Guyanese who were living in poverty in rural areas, and they suffered. The children suffered terribly from worms. Even the adults often suffered from them, and that made them. They weren't necessarily aware that they were there. They were intestinal worms, and makes you anemic. So then you have no energy. You're tired all the time, which the low iron makes the baby's brains not grow properly. and then as they grow up, they just can't fulfill their potential. They're tired, and they have not developed to their cognitive abilities, the cognitive potential, so that so that their lifelong earning is down, and then it continues the cycle of poverty. And we gave this deworming medicine, which you could give just easily, just line the kids up and deworm them. And we did some pilot trials with this, and we found over 80% the next day would poop out a ton of worms. So both the large ones you can see and the small ones you can't, that we would see under the microscope. And we did finger pricks and showed so many of the children were anemic because of this. And so we would go into these areas and just line all the kids up, go into the schools and line all the kids up, give them deworming medicine, just squirting them into the kids' mouths, and then give them Flintstone vitamins.
Yes.
And one Flintstone vitamin a day for 20 days loads them up, gives them the vitamin A that they need to help fight off many of these infections, and has been shown to save lives dramatically and prevent childhood blindness that was a scourge. And before we started doing this, we were seeing all this acquired blindness, and after we started doing it, it stopped. We stopped seeing any new blindness in those areas where we were able to service, and we were able to do huge numbers of children, and the program expanded, and it made a huge difference. And 20 Flintstones is not a lot of money, and you could make massive differences with doing small things, and those opportunities are still there. Both everywhere in the world where people want to look, there are opportunities to make a real difference. And even I naturally think of it with medicine, but I do believe in the pay it forward and the kindness from speaking to someone, and so the little acts of kindness that people can do can make a huge impact on repairing the world. And those opportunities are never going to go away. But if we recognize them and act on them, it makes life beautiful. Like, life is, for me, making those differences and doing those things gives life a huge, it makes it feel bountiful, makes it feel like there's really something we can do that makes life extremely special, because of all the lives we were able to touch.
Yes. Now, Michael, you have a thing about poop.
Yes, I do.
Dr. Silverman, my dear friend,
Yeah.
is a pioneer in the field of fecal microbial transplantation for treatment of, you help me with this,
C. difficile, Clostridium difficile, which, so we've been using it in a number of areas. The first way we started with people with C. difficile. So C. difficile is a potentially life-threatening infection. It causes severe diarrhea. It is diarrhea from hell. It is awful. Anyone who's had it will tell you how awful it is. And particularly in older people, it can be associated with a high mortality. It's a huge problem in our hospitals. It's because we use antibiotics a lot. We need antibiotics because a lot of what we do, modern surgery, etc., would not be possible without antibiotics to keep infections at bay when we have to, make a surgical incision. And we need, and antibiotics, there's no question, have dramatically decreased the death rate from so many previous scourges and still significant threats from infection, back to typhoid fever and tuberculosis and all this stuff. However, when we wipe out the healthy bacteria within the gut, this bacteria, C. difficile, overgrows. And it could be a huge problem. And it's you say, well, just give an antibiotic to kill that, but it doesn't. When you give an antibiotic to kill the C. difficile, you can't kill every last C. difficile, and those antibiotics also kill more of the healthy bacteria, and the healthy bacteria in your gut is what controls C. difficile. So it's like you're living on a farm and you're trying to get rid of the mice, but the treatment you have also kills all the cats. And all you need is one pregnant mouse left, and it's going to come again. And it comes again and again and again. So the solution is to give back healthy bacteria. So going back 21 years now, back to 2003, I started doing these fecal transplants where we take poop from healthy donors. And it's a whole long story how we do that and how we select them, because initially we didn't know how, and then initially we didn't know how to make sure that those people were really safe. Initially we took family members because we thought, okay, they're going to have similar poop. And I remember one of the first times we did it, and a family member came in and brought it and said, okay, we'll drop it off. And we checked their stool for like routine parasites, and it was all negative, and said, okay, let's come in and we'll do it. And she said, okay, and she came into the emerge, and we were going to do it there that day. And she said, oh, it's a good thing my Crohn's isn't acting up.
Whoops. Yeah.
Yeah, no, I don't want to prove. There's been theories that Crohn's could be is a transmissible organism. I don't want to be the one to prove that Crohn's can be transmitted.
Yeah.
So that we're going to cancel, and so we had to get more and more complex screening of our donors to make sure this works. We now on average, we published a little while ago, we had to screen 43 people to find one person who passes the screen. Often say it's easier to get into Harvard undergrad than it is to become a poop donor. Your odds of getting accepted are higher to Harvard, but it means you're really fit, you're really in good shape, and initially we were doing them. Initially we were doing them by enemas, and there was some people were doing it by treating themselves after we screened the donors. There was the do it yourself fecal transplants, and I emphasize this should only be done under a physician's guidance, because it should not. We're not encouraging that, but because it's got to be done properly and to make sure that it really is safe. But done properly and safely, it can save lives from C. difficile. And we made huge strides with that. More recently, we've been looking at it for other conditions where the gut microbiome, the organisms living in the gut, are critical. We used to think, poop is just leftover food, and it doesn't do much. But we now realize that it's actually predominantly bacteria, and that many of these bacteria are very active metabolically. They are doing a lot of things, and a lot of those things are very helpful to us. Some can be harmful, some can be helpful, and we're looking at it for multiple other conditions. Most exciting recently has been our use for this in people with cancer, where they go on immunotherapy. Immunotherapy is where you get a drug that helps your immune system to attack the cancer. And that's a very hot topic in cancer. And we're now finding that when we give fecal transplants just before the immunotherapy, we're able to increase the efficacy of immunotherapy, possibly as much as double the efficacy, to double the response rates, and which is a huge step forward. And we're conducting a number of studies, one that's about to start going across Canada, others that are both in melanoma, which is a skin cancer that kills people. We've got another study in breast cancer, in pancreatic cancer, in kidney cancer. There's a lot of excitement going on about this. It's still experimental. It's not ready to be done as a routine. But within these trials, it's in lung cancer, particularly, and melanoma, where we have the best data, it's looking very exciting.
You know, I don't mean to be little here, but I can't help wondering, as I'm sure many people do. Um, we had a dear friend by the name of Dr. J. Keystone. God bless his soul. And he really helped us in terms of the development of Yahafta and our medical responses to the world. And I remember Dr. J would have us down to his office, you and I, and he was known for his slides. And I would be watching these slides, and I had to turn away most of the time because you would see these worms jutting out of a person's body, right?
Yeah.
And I remember that there was one slide, either this came from you or him. It was probably you. You went to visit a prison in Guyana, and some of the prisoners had this awful infectious disease, which made their testicles the size of watermelons. And I could not look at these things. You're talking here about fecal transplants and so on. Are you at all squeamish?
I am.
Are you? You are squeamish?
We all are, but different things cause different people to be squeamish. So I have some friends who do, like, I could never be a dentist. I just find when teeth are, teeth, and it's so painful, and they're inducing pain with doing the, like, nah, it's too much for me. I can't.
Not for you.
I couldn't, and not for me. And then, I've got a dear friend who was an ear, nose, and throat doctor. And I could never do that. I find snot gross. Like, it just turns my stomach. And, but, and like sometimes the worms, I mean, everybody, sometimes worms is like, oh my God. But I focus on curing them, right?
Yeah,
And so I focus on what we can do about it. I'm not good with poop myself, but I find the whole science behind it fascinating. So I'm not usually the one who actually makes the poop. We make them into capsules. I'm fortunate that I have people who are wonderful and talented who work for me who do this. Mm-hmm. So there are ways to get around it.
Do you ever turn away?
You never turn away in terms of like having someone see you and look at that, because that is humiliating to the person. Like, what they are is disgusting, and you would never do that. Do you ever inside feel like you would like to?
Yeah.
Yes, but you don't, because that's the person feels then they are not worthy, or they are not. And it's really the person. And that's where I try to focus, not the disease, the person. And I do see the disease, however, as an opportunity to help the person, and I see it as the enemy. I remember there's a great ID doc, Irv Salat, who still works part-time, and he trained me, and I was a med student at the time, and I didn't know what I wanted to do, and this patient had I just I was going to be a doctor. I actually went into medicine thinking I was going to become a psychiatrist, but I'm pretty far away from that. But this person had a staphylococcal infection in their blood, and so he said, "Let's go to the lab and let's go see our enemy." And we looked under the microscope, and there was these little bluish dots that were from this person's blood, that had been grown from this person's blood, and they were the enemy. And our job was to exterminate them. And it was a clear, the moral, like, there's so many things in our life, in the world, that are morally gray. There's no gray here. I have no empathy for this bacteria that's in this person's blood. I want to kill it before it kills them. I have no question saying there's all kinds of hierarchy about animals. But I have no question. I don't feel uncomfortable saying I'm going to kill this microbe so it doesn't kill this person. And that doesn't, to me, seem gray. There's more than enough Staph aureus in the world. We're not going to make it extinct. But we're going to get it. It has no business being in that person. So I'm an exterminator for your personal house. And although with fecal transplants, I'm the opposite of an exterminator. I'm bringing helpful things.
Yes. Yes.
But it's exciting, you know. So rather than turning away from what's gross, it's seeing this is something I can do battle with. So like in Harry Potter, if you see the evil ones, you know, the Death Eaters or whatever, you know, the Dementors or whatever they are, there's all these different ones. They may seem gross, but the idea of going to battle with them and finishing them off is something I find very attractive.
I love that. I love the way you look at things. It is magical indeed.
Yeah,
I asked you once, what would you have done had you not been a doctor? And I said you would probably have written novels or children's stories, right?
yeah. Well, I thought of that. I spent time thinking about you know, and
Yes.
and I still got a couple of novels in the back of my mind that one day when I retire I might write. But if I ever retire, but because I enjoy doing what I'm doing too much. But yeah, I do love. I do love looking at. There's a magical side of life, and when you can see it, when you're blessed by because one of those things you see it, all of a sudden you realize, wait a minute, this is great.
Yes. Yes.
This is great. And medicine has given me a lot of those experiences.
I know that you're a man who is very much into process, who's very much into creating rules for yourself. We had a wonderful discussion last week about how you decided that you were going to start studying for university. And you developed this whole process, which you shared with my son. And I'm very thankful, by the way, that you did that. But what I thought about was how ingenious it is that you will sit down and think something through and develop a litany of rules, obviously applying consistency to them, to make whatever happens. When it comes to doctoring or being a doctor, I think one of the things that is most challenging for individuals, in particular if they're patients in hospitals, is doctors' bedside manners, which isn't always that great. I've had my experiences in hospitals, and sometimes I would be approached by doctors who are just marvelous in terms of how they operate and how they act towards me, and other times not at all. What are your rules, Michael? And what have they been for all these years in terms of how you respond to Mrs. Zimmerman,
Right.
who's lying in bed? She's an old lady. She has her family outside waiting. She's not well. She's suffering, and she needs you, and she's frightened. What are your rules for that?
Now, I would like to say that I figured it out, and there's a set of rules that works all the time. The best example I can give you as to why that's not true, I remember early in my training, I had a patient, and this was quite a while ago, and this person was a subspecialty surgeon in this very narrow area, and he was the world expert on this particular kind of cancer. And he had published enormous numbers of papers on this. He'd given lectures at international conferences about this, and he came down with that cancer. He came down with the very one that he'd been studying all the time, all these years, and he was the world authority. And then I was on the surgical service, and he was admitted, and then we went to see him, and so I talked to him a little bit and presented him to the staff, who was junior to this patient, right, who had been trained by this doctor, and he knew this guy knew way more about it than he did.
Mm-hmm. Mm-hmm.
And the patient knew way more about the condition than the physician did. And so the patient, went, and so what we had been taught, always was the approach was, well, you discuss the pros and the cons, and you discuss, the different approaches, whether we should treat this surgically, whether we should treat it with medications, whether we should use radiation, what should we do in this situation? And he was the one who wrote most of the guidelines about what to do in this situation. And so, the staff who was supervising me, spoke to him for a while and said, so, as you know, and he kept saying, as you know better than me. He kept saying, we can do this, we can do that, we can do this. What would you like? Right? And the patient, who was the surgeon, said, I want you to tell me what to do. I need a doctor. I'm not the doctor here. I want you to tell me what to do, and I'll do what you tell me. Now that's the opposite of what I would have expected, that you should talk to everybody and your job is to give the information, and ultimately you want to give the person agency and you want to give them a sense of control over their own life. But there's many, and we do that. And many times that's what people want. And some people really want that. And then you have to give that. And then some people really want you to, it's too scary. They don't want to decide because it's their own lives. This is a person who made that decision for other people countless times, but didn't want to make it for themselves.
Yes.
Because it was just too scary. And so different people need different things. And so there's not a right way to treat people. You hopefully come gently and try to sound people out to find out what they're looking for and try to give them what they need. And many people need different things. Some people really want you to be empathic and hand-holding and to really help them through this emotionally. Other people want you to be scientific and to be a little aloof, because that gives them a sense that there's an expert here who's telling me what to do, and they're not looking for a friend. And I've had people tell me that. I'm not looking for a friend right now. I don't want you to make small talk. It's not going to make me feel comfortable. Other people is like, well, you're just getting right down to business, and I really need to. So, and you try to switch with what they want.
Have you been good at that?
I don't think anybody is perfect at it. I try to be. I constantly aspire to try to recognize what that person needs and to try to give them what they feel they need. And it's hard because you're often walking into a room with someone who's in in a crisis, and you're meeting them for the first time. It's not like you have a whole history of what this person is like. They're often seeing you, as a specialist, they've seen a whole bunch of other people before, and they're feeling like, this is my last chance to get this right. Mm-hmm. And if this doesn't work out, I don't know what's going to happen to me. And it's very high stakes for this person. And, as the physician, it's easy to just feel, well, I've seen hundreds of people, thousands of people with this condition. But for that person, this is high stakes. It doesn't get much higher than your life is, or your well-being, or your family members are, this is very high stakes. And so very quickly, they're going to make an assessment about what you're like and whether you're giving them what they want. So you try to be professional, friendly, try to walk an even keel between different ways and try to sound out what seems to be working for them. And if they look down or whatever and look aside, and you realize, okay, that approach is not, maybe I got to change direction, because that's not what they're looking for here. And but it's trying to read people and try to read them quickly to try to find out what they're looking for. And sometimes you'll have several people in the room. There's the patient, the patient's mother or husband, and they're looking for totally different things. And that can be really even harder to navigate, because one wants you to be more like this and one wants you to be more like that. And, and then I just say, look, and sometimes I'll ask the person, do you want me to advise you what to do, or do you want me just to give you your options and give the pros and cons? Because I can do both. I can do either, right? I can go one way or the other. Or do you want me? And there's some people who they want you to joke around because they want you not to be so aloof and professional. They want you to be more accessible and down to earth, and that's great. And I'm happy to. I like that. There's some people who get offended, going, this isn't a laughing matter. And then you got to step back. Like, I was just trying to lighten your load with some levity, but I understand that this is very hard. I will not do that again.
How do you tell someone that they're dying?
Well, we used to have to do that a lot with AIDS. We used to do that a lot. The good news is, in infectious disease nowadays, I don't have to do that as often as I used to. Very rare. Now that's more common in certain other conditions, with oncologists and many other conditions where they're not treatable. But the good news is I've gotten out of the habit. When I was, 30 years ago, I was doing that multiple times a day. Now, the reality was many people already suspected it. And I also had the wonderful experience of people who thought they were dying, and then we got the new drugs. And I said, it's not necessarily going to be the case anymore, and we can fix this. And now, more commonly, I have people coming in with HIV who think they're going to die, who I say, no, we can fix this.
Yeah.
If you can take one tablet a day and not forget to take it,
Amazing.
you can live to be an old guy.
Amazing.
And a healthy old guy. So that's lovely. That's lovely. It's probably, it's sweet for anybody. It's extra sweet for me because I remember what it was like before. But I'm glad I'm getting out of the habit where I'm getting more rusty at telling people they're going to die.
Thank God.
Yeah.
What do you like with little kids in the office?
Well, I see a lot of, when working in Africa and South America, you see a lot of kids. I'm an adult doc. So most of the times when I'm seeing kids I'm an adult specialist, it's because their parents have brought them. But I don't see too many kids here. Now I see a lot of, when I was working in Africa and South America, when I was working in Oshawa before, there was a pediatric specialist there now, pediatric infectious disease doc, but we used to cover for each other because there was only one of him and there was one of me for a while. So I'd see more kids. I loved it. I really loved it. Like I really, and I still do. Like I get a real, I don't know, kids give me a thrill. So in terms of like, it's just, they can be really a lot of fun. Now, when a kid is sick, it's really hard. It's really hard.
Yeah, this is what I'm asking.
Yeah, when a kid is sick, it's really hard. And when I saw them in South America and in Africa, the good news is most of the time when I was seeing them as an infection specialist, there's something we can fix. I debated going into oncology, but I'm not the kind of person. It takes a real strength, and there's different strengths I love out of medicine fixing things.
Yes, yes.
I like,
You're like a mechanic.
yeah, I like fixing things. I find it, to just see somebody and say there's nothing we can do about it.
Yes.
Some people can get satisfaction out of it because they've given the person the answer. And the answer is, you have this, and there's nothing that can be done about it. And I respect people who we need people like that, because somebody's got to do that. And the only way we're going to move forward is enough people can identify what it is. And then hopefully that leads to research that will come to an answer. But for me, what gives me a zing is I fixed it.
Yeah.
I fixed it. And even if I haven't fixed it yet, most of the things I've thought about are fixable.
Yeah.
So if I really do my job well, I can fix this. And the few that aren't fixable, you get over. You'll usually survive it. So I can make it better faster, or I can, but so that's why I went into infectious disease, because I love fixing things, That's what gives me my zing, right?
It's good you didn't become a psychiatrist. It really is.
Yeah, well,
Because fixing can take years.
Can take years.
Yes.
And I realize that. Now, some people, see a psychiatrist once or twice, and or a social worker or a psychologist, and they come, oh, that's it, and they have an epiphany. Other people, but I did find it difficult. The person has to do so much of the healing on their own that it would make me feel that my hands are tied. Now, the reality is, many times, even in infectious disease, if the person's not going to take their antibiotics, or they're not going to, they don't, for various reasons, some people have mixed feelings about, following through with what they were advised, often because they're self-loathing or there's other reasons. I mean, we still lose people from HIV, often because of addiction, and they just can't take their meds.
Well, I have to tell you something. I have a blister pack full of meds for my heart.
Yeah.
And I take them twice a day. And it is onerous, and I resent it sometimes. I do. Why do I need these things to keep me alive or to keep me ticking, right? I don't want to do that. I don't want to do this. I really don't. I don't want to be part of that system. But Michael, I have another question for you. I think on your best days you're an agnostic.
Yeah.
On other days you're an atheist.
Yes.
Do you ever pray for patients? Just despite all of that?
So as you point out, it depends on the day.
On the day,
I believe. So there are some days that I think that it can be very comforting to believe in a higher being that is watching over us, that cares and makes sure that things work out the way they're supposed to.
Yeah.
It's very comforting. And but on some level I'm a scientist. And I believe in Occam's razor, and if you don't need this for an explanation, then it's probably not really there. Like, if you can explain things, the simplest way you explain things is probably the simplest way is we're here alone.
Mm-hmm.
So most of the time I think that way, but I don't always think that way. As you know, there are many times, losing a loved one, that you just want to believe they're still there in some way, and that you can still reach out in some way, and so there are times when I do feel that way. Do I feel prayer is helpful? Yeah, I do think prayer is often helpful, because it's helpful to express your deepest needs and wants. And it's helpful to do that, and it often is healing on its own in its own way. And do I sometimes pray or wish for patients? Yes, I do. And do I sometimes pray for family and for others who are in trouble? Yes, I do. And do I think it's rational? No. But there's some evidence it might help anyway, but that's limited, and there's always problems with those studies, but it feels better. And you're just trying to do everything you can. And it's just natural. You just feel the need to do it. So yes, I do sometimes. You want to do more, and you really hope that you can help. Sometimes you have to acknowledge not all problems are solvable, but that's a last resort, and I prefer to fight to the end.
There was a beautiful article that was written about you and your dad. It was called "A Father's Legacy, A Son's Calling."
Yeah.
And it begins like this. When Michael Silverman's father came home one evening with 2 live chickens
Yeah.
as payment for legal services, your dad was a lawyer. It was a lucrative day in the Silverman household, even though his mother had no idea what to do with the feathered fowls.
Yes.
Your dad was a beautiful soul.
Yeah, he was.
God bless his soul. He died way too young.
Yeah.
And he was one of those individuals who would give of his legal services to many people who were poor, impoverished. And they would say, "Mr. Silverman, I just don't have the money to pay you right now." And like the old store owners, when our parents were growing up, he would keep a little cheshbon. He would keep a tab, or maybe he'd never ask them for money at all, or maybe he would take 2 chickens.
Yeah.
And I would go ahead, please.
No, he was like that because, I mean, his sense was you help those who need you. You don't help. You don't just help because they can pay you. You help because they need you. And he also had this sense, he was a lawyer who he did, he was one of the old-fashioned guys. He was a generalist. You do whatever you can do to bring in, to keep the place going. But he did a lot of criminal. And back in the day, there was a lot of, there was, racism and stuff was overt in many ways. And there was a very strong negative image of immigrants. I won't say that that's all gone now, unfortunately, but it was very dramatic then, and a lot of immigrants came, and a lot of people came from the Azores and came from other. Were coming in different waves at different times, and they were treated, and many of them were called illegal immigrants. And my dad had, and they couldn't pay, and they were just. And my dad said, look, they had a lousy life. They were poor, and so they got on a boat to try to get a better life for themselves and their kids. What's the crime? For crying out loud. And then he'd look at people going, well, it's illegal. And they would always say, how did your grandparents get here?
Yeah.
They got on a boat. Like, just they came here, in the late 19th century or whatever, or the early 20th century. And they got back in the day when you could just get on a boat. And then they changed the law to say anyone who does what you did is a crime. And though they're doing it for the exact same reasons and the same motivation. And how can you, he said, and like as Jews, he said, we were refugees. These are people running because they came from extreme poverty or came from a dangerous situation. And they want to, so he's going to help them. Almost none could, his practice, over a third of people had no hope of ever being able to pay. But he'd go, look, the guy came in and he's a nice guy. He's just trying to help his family. So, he would take on the case, and it would be a lot of work. My mom was very bright. But she would go like, I went to university. I had straight A's in university. You want me to pluck chickens? And he goes, well, no, that's what he could give us, and let's celebrate because I won the case. They framed him, the cops framed him. And they did it because of his color or because of this and because of that. They didn't like the way he looked. They didn't like his religion. They didn't like it. And they said, get out of here. And they framed him. And I showed those guys, you can't do that. Right. So it was a rabble rouser, and like, you got to go to bat for the poor because, we're lucky enough. He said, my dad came as an immigrant and fought and worked and, and scrounged and tried to put enough together. And then, I worked and then studied at night. He was a roofer and was hammering on the roof at night, and he put the notes from last year's law school exams on the roof and tack him in, and he'd be flipping pages while he's doing the eaves trough. So, and got himself through, and he said, well, I've been blessed that now I'm a lawyer. So now it's my turn to pay back. So he always told me, that's what he said, go into medicine, you can help the poor, and there's OHIP, and you'll get paid. So what did I do? I found people in Africa and South America that don't have OHIP, so that I could help them. But but I did learn from him the value of the great sense of satisfaction you get when you help someone, not because they paid you, but because it was the right thing to do. And knowing that if you hadn't done it, they probably wouldn't have gotten help. Mm-hmm. They probably wouldn't have. It's not like they would have gone next door to the next firm and they would have gotten something else. They probably wouldn't have gotten anybody because this was before the days of legal aid. If there weren't guys like him to take it on, they'd just be deported.
Would your dad be proud of you?
I like to think so.
Yeah.
I like to think so. So, it's one of those things where you see your parents' highest values and you want to live up to them. Mm-hmm. It's a tall thing because he was a very moral and upright guy, but I try. So
I want to thank you a lot for this interview.
Yeah, thank you.
We've known each other for a long time, and I did not have to do much research whatsoever for this interview, which is unlike most interviews because I've watched you in terms of your life and your career, and you've really done a magnificent job. You really have put your best foot forward. And I think you're right. I think that you have taken a look at your mom and dad's values and you've brought them forward to your own life. And I saw that here in Toronto. I saw that in Guyana, in Zimbabwe, and other places that we worked. You were always inordinately kind to the people we were working with, to our partners, to our donors, to our suppliers, the pharmaceuticals, the Apotex of the world, the Nova Farms of the world. And you gave of yourself in a really special way. Sometimes, people often wonder, who am I? Why am I here? What is my task in life? What is my mission? Who am I naturally that I can actualize that and bring it to the world? And like you said at the beginning of our interview, I think you figured that out early on. And that is muzzle, my friend. That is luck.
Yes, it is.
A lot of luck in understanding what your nature is and what your skills are and what you have the ability to do. We are very lucky to have you.
That's kind of good.
We are very lucky to have you. I'm lucky to have you as one of my dearest friends. And I love you with all my heart.
That's fun. I love you too, Avrum. You've been awesome to me. You've been awesome. Got a lot of stories going back.
You have inspired me. You've inspired our dear friend Ellie Rubenstein and so many others. And you also fascinate us with what you know, what you learn, how do you try to develop. So not trying to be obsequious here at all. This is coming from my heart. It really is. And I think you deserve to be honored. And I find great pleasure in being able to have that opportunity here today to honor you. I really do. So thank you. Thank you for giving me that opportunity.
You've been very generous. You've been very generous. I'm very privileged to have you as a friend.
So I wish you well. And I would ask our viewers and our listeners to watch this interview throughout. Sometimes people say, Avrum, you go on and on. And I say, well, if you like the interview, break it up into half or break it up into thirds. They're well worth listening to. And I would argue very strongly that this interview will stand out in time for many years to come in terms of the body of work that I'm trying to create here with my dear friend, Dr. Michael Silverman. So I wish everybody well. We would like to dedicate this to all the people out there who perhaps are ill today and are looking for health. We send our blessings. We send our positive energy out to them. And we hope and we pray that the time comes where you can stand up and be strong and bring to the world what you have within your soul. So we will talk to you soon. We will be back very shortly. And once again, thank you, Dr. Michael Silverman.
Thank you.